Welcome, everyone. We'll be giving a couple of minutes here for everyone to join, and then we'll get started. You give everyone a couple of minutes here before we get started. Not yet. They do it later. Okay, we'll be starting here very shortly as folks are joining. Okay, so welcome everyone. I'd like to welcome everyone. Good morning or good afternoon, wherever you might be, and thank you, all of you, for joining us. I'm Judy Monroe, President and CEO of the CDC Foundation, and I'm excited to welcome you to our latest in our Lights, Camera, Action webinar series, Strengthening the Public Health Workforce. The CDC the CDC Foundation is an independent nonprofit organization, and we work to extend the life-saving work of public health both during normal times and during emergency responses like the COVID-19 pandemic. So as we get started, I'll share a few housekeeping items with you. Because of the large number of attendees, we're not going to use the chat function today, but importantly, you'll still be able to submit questions during today's panels using Zoom and Q&A feature. Slides and a recording of this webinar will be made available on the Lights, Camera, Action website, which is all one word, futureofpublichealth.org. So beginning in late 2021, the CDC Foundation worked with partners to develop the Lights, Camera, Action webinar series or summit series to begin conversations about what public health might look like in the future. The lessons we were learning and the specific steps we could take going forward to build the public's trust and ensure everyone in our communities would have an equal chance to achieve emotional and physical wellness. And now we finally have a moment to step back and reflect on the incredible storm that we weathered together. And as you know, COVID-19 was the worst health threat in more than a century, and it tested our systems and it revealed our weak spots. Here in the United States, COVID-19 tragically took the lives of more than 1.1 million people. Each of those lives lost represent an individual, a family member, a friend, a neighbor. So I do want to take a moment to thank the public health professionals with us today for all of your tireless efforts to keep that number from growing any bigger. In our discussion, we're going to talk about ways that we can thoughtfully and intentionally leverage this event to strengthen our public health systems and services with a specific focus on workforce. So one of the CDC Foundation's major efforts during the pandemic was recruiting more than 4,000 staff and embedding them into communities across the country, into state, tribal, local, and territorial health departments to support their response. One of these projects, funded by CDC, was the Workforce Vaccine Initiative, which placed a diverse group of 3,000 people into a wide variety of positions within 91 jurisdictions. These roles ranged from epidemiologists and vaccine demand specialists to communications officers, environmental health coordinators, budget analysts, and health equity managers. The impact of the Workforce Vaccine Initiative was undeniable, and many of those 3,000 workers who were new to public health have continued to pursue careers in the field. We are excited about this, and we want to keep that pipeline going. So today we have over 1,000 participants that registered for the webinar, and representing just about every corner of the country and our nation's public health community. And in registering for today's webinar, many of you shared what you see as the challenges facing public health. For instance, you all identified the politicization, that's a tough one to get out, but politics involved as a critical issue of public health, as well as funding adequacy and sustainability, along with state and federal policies. Several of these issues are longstanding, tenacious problems, and our discussions will certainly touch on them. In addition, you raise concerns about workforce and capacity, calling for better training, greater diversity, and experienced leadership. Here's where together we can all make a difference. We have a terrific group of experts with us today, all leaders in public health, each bringing ideas and insight based on many years of experience. You'll have the pleasure of hearing directly from some of our jurisdictional partners who will share their experiences around innovative strategies for building capacity, as well as leveraging partnerships and community engagement to advance health equity. We'll round out the summit with a call to action discussion where we'll chat with some of our national public health leaders about specific strategies for policy, workforce recruitment, and systems change to strengthen our nation's public health workforce. So I'm delighted we have with us today one of the key people who advocated for CDC to focus on the public health workforce, and it's my pleasure to introduce Dr. Patricia Simone. Patty Simone trained in internal medicine and infectious diseases. She now serves as director of the Division of Workforce Development in CDC's National Center for State, Tribal, Local, and Territorial Public Health Infrastructure and Workforce. Patty's a passionate advocate for public health training and education. She joined CDC in 1992 in the Division of Tuberculosis Elimination. Between 20 and 21, she served as CDC's acting deputy director and later as the acting director of the Center for Surveillance, Epidemiology, and Laboratory Services during CDC's response to the COVID-19 pandemic. So please join me in welcoming Dr. Patty Simone. Patty, over to you.
Thank you, Judy. It's a pleasure to be here again with all of you today from the first summit that we did on workforce back in December 2021. I'm really happy to join the conversation with you and see where we're headed. Next slide, please. I'm going to just talk briefly about what we knew, what we learned, what we did, and what's next. Next slide. Even before COVID, we knew that decades of underinvestment had undermined the public health workforce with shrinking numbers and capacity, with approximately 56,000 fewer workers in 2020 compared to 2010, and with the 2021 Staffing Up report estimating the need for an additional 80,000 full-time staff just to provide the minimum public health services. Next slide. COVID further highlighted the fundamental role of the public health workforce in responding to emergencies and demonstrated the consequences of that underinvestment. We also learned that despite the influx of emergency funding, funding wasn't the only barrier. There were hiring barriers at federal, state, and local levels. Skills had not kept up with changes in technology. There were issues with diversity, equity, and inclusion, and we didn't have the systems and data to assess and monitor what was needed. We also learned that flexibility is key. Health departments have different challenges and barriers, so a variety of flexible solutions were needed. And we had to be flexible in adapting to the new remote work environment. But we also learned that remote work opened up new ways for more staff to participate. Next slide. I'm going to go over a few examples of what we did with the influx of emergency funds to help address workforce needs. I was working on the response when the CDC Foundation Workforce Initiative was being started. I want to commend the foundation for their flexibility in adapting the initiative to health department needs. When we started, we thought we were going to be sending hundreds of contact tracers to the health departments, but the foundation staff really listened to what the health department said they needed, which was not just contact tracers, but rather a wide range of positions, including epidemiologists, data and laboratory positions, and more cross-cutting positions like grants management, administrative support, and communications. They were able to change course and hire over 3,000 staff working remotely, and they did so with minimum burden on the health departments. I have heard so much positive feedback from health departments about how valuable this initiative was for them. Another example is Public Health AmeriCorps. This is a joint effort between CDC and AmeriCorps, building on the expertise of AmeriCorps to help meet public health needs of local communities by engaging a whole new group of people who may never have considered a career in public health. It will help build a more diverse workforce by developing pathways to public health related careers through on-site experience and training, with a focus on recruiting members who reflect the communities in which they serve. The plan is to support more than 4,000 AmeriCorps members in both rural and urban communities. In April 2023, the second year of grant funding, totaling nearly $90 million, was awarded to more than 100 state and local organizations, building on the first year of funding, which provided nearly $70 million to 82 organizations. And as of March of this year, Public Health AmeriCorps has enrolled more than 1,500 members at more than 500 sites across the country. One of the ways we are addressing the limited data about the public health workforce is a jointly funded program with CDC and HRSA, the Public Health Workforce Research Center. The award was given to a consortium of public health workforce researchers led by the University of Minnesota. During the first year, they have embarked on a variety of studies looking at workforce data sets, workforce composition and supply, workforce assessments and gaps, career ladders, and a review of state hiring laws. We are looking forward to the results of the year one studies and the initiation of additional studies in year two. Then, taking from all the lessons we learned from these efforts and many others, we had the opportunity to develop something new and highly flexible to address public health workforce and infrastructure needs, the new Public Health Infrastructure Grant. Next slide. In November last year, CDC awarded $3.2 billion to 107 state, local, and territorial jurisdictions across the U.S. to strengthen their public health workforce and infrastructure. It is designed based on jurisdictional needs and allows maximum flexibility so that health departments can address their own workforce and infrastructure priorities and meet their most pressing needs. It funds 3 national partners, ASTO, NNPHI, and FAB, to provide training, evaluation, and other technical assistance to jurisdictions. Finally, the grant is designed to reduce administrative burden and allow jurisdictions to work with a single project officer and access multiple streams of funding from CDC. One of the really unique features of this grant is that the workforce funding, $3 billion in emergency funding, was awarded based on a formula with the full funding for the 5 years awarded upfront. One of the only requirements is for each jurisdiction to hire a full-time workforce director to coordinate workforce planning and other activities for their jurisdictions across federal funding. We're really excited about the 5 years of work that this grant and its potential for transforming the public health infrastructure. Next slide. This work will continue in the new center formed as part of CDC Moving Forward, the National Center for State, Tribal, Local, and Territorial Public Health Infrastructure and Workforce. Public health infrastructure means the people, services, and systems needed to promote and protect health in every U.S. community. The center advances 3 functions with 3 corresponding divisions: jurisdictional and tribal support, partnership support, and my division of workforce development. The new center is leading efforts at CDC to reduce the administrative burden for jurisdictions with their grants and work more seamlessly across the agency. For example, the grant team is working with several programs outside the center, including the Epi and Lab Capacity and Public Health Emergency Preparedness Cooperative Agreements, to move forward toward using the same platform for technical assistance and reporting. Also, the center is committed to continually improving the way we do business by listening and acting based on feedback from health departments across the country, including plans for an agency-wide customer satisfaction survey and to identify more enterprise solutions. The new center will support the health departments to make the work they do stronger and more effective. I, for one, am very excited to begin working with the 107 workforce directors as they are being brought on board and support learning and sharing of best practices among that group. As we all move forward together to make the case for sustained investments and support for public health infrastructure and workforce, and to promote and protect health in every U.S. community. Next slide. So here are a few links for people's reference of some of the things that I talked about. And Judy, I'm happy to answer a few questions.
Terrific. Well, thanks, Patty. And I share your enthusiasm about the 107 full-time workforce directors. I mean, that's really awesome. So yeah, first question I have for you actually is from CDC's perspective. What do you see on the horizon for public health workforce development, ensuring capacity to respond to the next public health emergency specifically? So how are y'all thinking about that?
Yeah, I think to me, the big thing is for us to really fully implement the public health infrastructure grant and the workforce components of that. There's a lot of work underway about workforce assessments and other technical assistance and other things. And then, very quickly, we need to be gathering what people are learning, what works best, the impact of the work so far, and sharing that so that everybody can benefit from that. And like I said, making the case for sustained funding. This is, an amazing amount of 5 years of funding, but it's not going to fix all the issues out there. And it's emergency funding, so it's not a guarantee to continue. So, figuring out how we can learn from what's going on while we're still doing it to make the case for the impact in the future. And I do think, the center was really set up to help address workforce and infrastructure needs, based on the lessons that we learned during COVID and the CDC moving forward. So a lot of plans there to learn what we can to make sure that we're have the best, most impact that we can.
Yeah, thanks for that. So in another vein, so looking at the COVID response, and it really introduced a new and a diverse workforce because of all the incredible need and all this diverse workforce now into public health. How do we build on the momentum to make sure that health departments are staffed by members of their own communities?
Mm-hmm.
And maybe along with that, maybe talk about the balance between folks from their own communities being embedded versus bringing in new ideas. There might be a balance in there.
Right. There's not like one approach and one right answer for all this. I think we do need a balance in different things. So I think that, using things like I mentioned, Public Health AmeriCorps, ways that we are learning that we can engage people who never really thought about a career in public health, and engage people who want to serve in the communities where they're from. And so we're learning a lot from that program too, and really excited about the early successes there. There's still a lot of barriers, and we need to figure out how to address those better. I do think there's an opportunity if we could really identify more funding for student loan repayment. I think that would really help to attract people into careers in public health from some of these communities, and also figuring out what really works. I think sometimes there's a lot of passion, a lot of things that people want to try, but we need to be careful to learn as much as we can about what really works, and we're doing several things with some projects that we have to make sure that we're capturing the things that do work, and then practicing the best evidence-based approaches that we can.
Yeah, I think the loan repayment is certainly important, and that can be both federal or state. I mean, everybody can have some skin in the game on this one.
That's right.
I know our work in Indiana, which I think we're going to hear about later, had workforce and loan repayment as some of the recommendations on the commission.
And HRSA has some programs too for loan repayment also.
Yeah, and it can be other agencies, right?
Right, that's right.
That's great, great. So one of the things that public health requires, we really require upstream solutions to downstream problems. So in terms of the workforce, what do you see as what's CDC doing to strengthen the public health workforce from a social determinants of health perspective? How are y'all thinking about that?
Yeah, that's a good question. When you were talking about upstream, I was thinking about some of the things that we're doing even in middle and high schools, thinking of public health as a STEM field and encouraging, we have some programs where we work with teachers and to help them have some curricula that they can use in middle and high school classrooms to get people interested in public health. There's something called the Nerd Academy, which is online and anybody can use that, to novel emerging respiratory disease is what NERD stands for in this case, and some online things that people can use. The other thing is making sure we have opportunities for students to do applied learning in their state and local health departments near the schools where they're doing their undergraduate or graduate work. I think we know that until people don't really catch the bug of public health until they have the experience in public health, and public health isn't the highest paying field, so really identifying people who have the passion and giving them an experience early in their education can help them really be interested and then pursue a career in public health later. And so we need to make those opportunities accessible. We need to make sure we're reaching groups that we haven't reached before, and making sure that we have internships, for example. We are trying to take better advantage of that at CDC. Some of the other agencies and HHS really do a really remarkable job with that. And those are paid internships, which is really important for accessibility, equity and accessibility for all. So those are just a couple of the things that we're working on.
Yeah, thanks. So we've got a question in asking, how did CDC and the CDC Foundation view the overall success of the surge staffing projects? And are there plans to do it again, perhaps for migrant and refugee health is the question.
Well, I don't think you or I know of any specific plans at the moment, but I do think that we learned a lot from that project, the initiative. And I just as I said in my remarks, thinking about where we started and where it ended up was, I really did mean it. I really want to commend you and your staff for, thinking we had the idea of what needed to be done, but then really listening and doing what needed to be done. So figuring out how we can have mechanisms for surge support and take advantage of being able to hire the best and the brightest from wherever they live, and they can support remotely jurisdictions when that's appropriate. But being ready for the next emergency, I think really, having our projects and things ready to go so we can flip the switch and get started and not have that startup period that we did. Of course, every emergency is a little different, and we can't just we have to do some adapting. We've all learned that over the years, but we certainly have a lot we can learn to be better ready for that.
Yeah, no, I agree. And Patty, I think for the listeners, this talking to you takes me back to those early days where we were having the conversations about how do we design this, how do we execute on this. And I want to commend CDC. I mean, because this was really there were a lot of phone calls and a lot of learning. Definitely two-way street, three-way street. Hearing from the field, working with CDC and with the foundation. So I really commend CDC for the work you all did. A couple of last questions here. Let's see. We've got one here. It's a thank you for all your work in support of the public health workforce. Even after the CDC infrastructure grant, health departments are still unable to recruit for long-term, sustainable, consistent public health jobs because they don't have access to the long-term, sustainable, consistent funding. So what are the opportunities ahead for long-term, sustainable, consistent workforce development initiatives to fund recruitment and retention? I think you were beginning to hit on that in
Yeah.
terms of
Well,
sustainable.
you know, no, in the federal funding is never guaranteed from one year to the next. So, you know, we want like funding in our base for regular core funding, that regular appropriations rather than emergency funds. But the fact that the jurisdictions have 5 years, that's a long time to plan, and it's more than a lot of other grants and cooperative agreements. So when we did our listening sessions, we heard that that 2-year grant isn't really helpful, that people can't always get approval to hire when there's only 2 years of funding. So we were really lucky that we had this opportunity to do this 5 years up front. So I think really calling upon everybody to make the best of this 5 years of funding, recognizing it's not, you know, enough, and it can't fix all the issues, but showing how this type of approach can really be helpful, can help us make the case for ongoing, sustained, you know, regular, reliable funding going forward, right?
Well, and I think you just articulated that's the challenge ahead of all of us, right? So this is going to take everybody to really showcase the work and the value of that investment. Okay, this is our last question. I'm going to maybe we both might try to answer this one, but the question is: best and brightest are frequently encouraged to consider medical hospital careers rather than public health, which is not viewed as prestigious and as well paying as the medical field. So how do we counteract and approach that problem?
It's, you know, it's a big problem. I think I do think addressing student debt is an important one, because people can have more choice in the careers they select if they don't have to worry about paying off their student loans quite the same way. So that's an important one. You know, I think it's just the same answer I had before, Judy. People who experience it and they catch the bug, you know, that's what drives them, and not just the salary. And you know, we've all experienced that, and we've all seen it, and it's not for everyone, and that's okay too. But you know, having the programs that we have in my division and others around the agency, and trying to get as many people to have that experience, and then some subset of them will have careers in public health, and we want to be ready and welcoming to all of them when they're ready for positions with us.
Yeah, no, I completely agree. I know a lot of people that found public health later in their careers and wished, and I'm one of them. I wished I'd found public health earlier in my career. Public health sort of found me, and it gets in your blood because you realize the power and the importance of public health. So, but yeah, thank you, Patty, so much for everything you've done for CDC over the years, and thank you for your amazing work during the pandemic and now the future work on workforce. So thanks so much.
Thank you.
Okay, so now let me turn to our first panel discussion, which is going to be moderated by my friend and former colleague here at the CDC Foundation, Dr. Lisa Waddell. Dr. Waddell will go ahead and introduce each of our panel members, but I have the pleasure of introducing her first. So Lisa joined the CDC Foundation in the summer of 2020. And Lisa, I remember those phone calls with you as well, recruiting you to come work as our chief medical officer during the pandemic. And in this role, Lisa tirelessly managed many of our COVID-19 response efforts, including directing a team of senior advisors and COVID-19 core surge staff who supported health departments across the nation. Before joining the CDC Foundation, she served as the March of Dimes Deputy Chief Medical and Health Officer and the Senior Vice President for Maternal and Child Health Impact nationwide. And before that, she worked with the Association of State and Territorial Health Officials and for the state of South Carolina. So Lisa retired from her role with the foundation in early 2023, so just earlier this year, but recently founded LFW Public Health Connections, a consultancy centered around leadership, mentorship, and partnerships. So please join me in welcoming Dr. Lisa Waddell, LFW, right?
LFW, that's right. Thank
W.
you so much, Judy. It's so great to see all of you and to join this esteemed group today. You know, my time and with the CDC Foundation during the pandemic really reinforced the power of partnerships, the importance of innovation, the critical nature and value of community engagement, and what we can accomplish when we all work together. So that's why I'm so honored to serve as your moderator for two of today's panel discussions, which will highlight many important lessons and practices that hopefully will be helpful to you as you continue to improve health in your communities and states. So our first panel is innovation in public health infrastructure. This panel will explore jurisdictional capacity and capabilities in the public health workforce and how the pandemic acted as a catalyst for innovative strategies. I'm excited to briefly introduce and welcome our three esteemed panelists from Hawaii, Indiana, and Maryland. You can find their full bios on the futureofpublichealth.org website. So our first panelist will be Dr. Amy Curtis. She is the Chief Administrator for the Adult Mental Health Division in the Behavioral Health Administration with the Department of Health in the state of Hawaii and serves as the state's Mental Health Commissioner. She has served as both an epidemic intelligence officer and a senior epidemiologist at the Centers for Disease Control and Prevention. Following her, we'll hear from Ms. Pam Patones. She is the Deputy Health Commissioner of Local Health Services for the Indiana Department of Health. And in this role, she is leading working committees for the Indiana's Governor Public Health Commission. She has a laboratory background and has served as the state epidemiologist. She also serves as the vice chair for the ASTO Senior Deputies Committee. And then following her, we will hear from Dr. Catherine Feldman, who is a veterinarian by training and is currently serving as the Chief Public Health Scientist in the Office of the Deputy Secretary for Public Health with the Maryland Department of Health. In this role, she leads initiatives and activities, including strengthening public health infrastructure, modernizing the public health data ecosystem, and local health department engagement. Now, our format is as follows. Each panelist will provide up to 8 minutes of remarks, and then we'll have a moderated Q&A. So we're going to hear from Dr. Curtis first, and she's going to discuss how the CDC Foundation staff supported the development of the Hawaii Department of Public Health Adult Mental Health Division. This will include building a system of care model and using public health linkages to address social determinants of health. And she's also going to touch on how we can recruit clinical physicians into public health. So with that, Dr. Curtis, Amy, I'm going to turn it over to you.
Thank you. And thank you for having me here today. Good afternoon for those of you on the East Coast and good morning for those of you in Hawaii or the West Coast. Really excited to talk to you today about what we were able to do with this initiative. This was incredibly helpful for our division, so excited to do so. So in the next slide, I'll talk a little bit about the Adult Mental Health Division. The Adult Mental Health Division includes almost 1,000 FTEs, which is approximately a quarter of all the Department of Health in the state of Hawaii. So quite a large division. And many of that, or much of that reason is because of the picture you see here. It includes the direct care staff that are assigned to the Hawaii State Hospital, the state psychiatric hospital. As well as that direct inpatient care, we also provide care through our community mental health centers in all 4 counties and 6 islands here in Hawaii, and that's for outpatient care. We also have direct care staff that are working in the clubhouses, an evidence-based psychosocial rehabilitation program, and we also have direct care staff that are doing the court evaluations to determine if someone is fit or competent to stand trial. In addition to that, we, through contracted care, contracted services, run the crisis center for the state, including the crisis line 988. Hawaii Cares is also our helpline for behavioral health issues, our crisis mobile outreach teams, stabilization beds, shelters, and other residential level of care all the way down to group homes or semi-independent or housing supports for individuals that way. So it's quite a large division, but it's been pretty focused on those direct service needs to individuals. So coming in as an epidemiologist, one of the first things that was apparent to me was there was a lot that we could do to grow in that public health model, and in looking at what we could do for those with serious mental illness or those adults with mental illness needs in our state from that population perspective. We did not have the first epidemiologist in the division until 2017. Many of our records are still on paper or in fragmented different settings. And we did have a strong accreditation system, so quality management, but still it was very difficult with this fragmented system that was there. So this came in during COVID with the CDC opportunity to have that staffing come in and help us was just amazing, because we were able to not only take specific positions that had been left open and would have taken a very long time to fill in, yet were instrumental to us being able to do the work we do, not direct services, but those behind the scenes, those data and those fiscal aspects and some of the other things that we needed to have occur. But we were also able to start and look holistically at what we wanted to do with data and how we wanted to move forward in this public health direction. So next slide. So within that, embedded in that, is still including these services that we need to provide to those with serious mental illness. And we wanted to make sure that we had a very integrated system. Because the data was so fragmented and so separated, that meant that much of the information in trying to care for individuals that were going from inpatient to outpatient, from outpatient to inpatient, or in different programs was very difficult for those who were caring for them to have and to understand the full histories and be able to share. So we wanted to be able to get all of the information into one system, be able to utilize that and think about the care of the individuals as a holistic combined system and not these fragmented, siloed systems. And that really helped us think about the seamless linkage of care for individuals and how we wanted to view ourselves. And we were able to do that through staff that included data architects, data scientists, epidemiologists, all coming in and looking at our data systems, as well as IT trainers and folks that were coming in to help those staff that were not used to entering data in the same way. And we're used to maybe writing things on paper or not collecting that information that was really important for us to have to examine what was happening with individuals and how we could help them. This was further accentuated during the pandemic. We had many direct care programs that were going on, and we were trying to constantly monitor what we needed to do with our COVID guidelines. So we were able to bring in and share pretty innovatively an epidemiologist between infectious disease and adult mental health division to look at all of the guidelines, what was happening, where we were seeing COVID impact the different staffing and patient populations that we were dealing with. And we also were growing our crisis care system during that time. And so we were able to look at the crisis care system and build the data systems as we were building the systems in real time that would have been very difficult to do before. So we had built out case management based stabilization beds, which was really helpful. And in doing all of this work, we wanted to be able to measure our outcomes and ensure that we were looking at it and not just measure those clinical outcomes that we've been doing, but look at it from a social determinants of health perspective too. So we were able to bring in epidemiologists that were looking at health equity and looking at our race, ethnicity, and some of the other aspects that hadn't been examined in the way they should have within the adult mental health division, in my opinion. Finally, workforce recruitment and retention was really important. For the for psychiatrists in the state of Hawaii, they are an exempt position. That allowed us to change the salary matrix more quickly than we would have been able to do in a civil service model. That's really helped us to recruit psychiatrists. Still very difficult, as I'm sure it is for everyone out there. We're also using the internships and developing innovative programs with our community colleges and our colleges to try to expand that pipeline of individuals coming in and staying. So that's what we've been doing, and I want to leave some time for others, but that's what we did with these staffing. And I do want to mention as a closing remark, all of the individuals are staying on with us through a special project that we're doing with the University of Hawaii, and some have become permanent staff. So everyone who's wanted to stay has stayed, and this has really led to a continuity of staffing and help in our data project and what we're doing. So very supportive and very thankful for CDC Foundation and CDC for this project.
Well, thank you so much, Amy. That was really fantastic. And it's really great to hear the continuity in terms of the workforce too, because we know that that's always been a challenge. So now we're going to turn to Ms. Pam Patones, again, with the Indiana Department of Public Health, who's going to highlight her role and work with the Indiana Governor's Public Health Commission and really focus on some issues around policy and how do you deal with some of the policy challenges and opportunities and provide some examples of overcoming barriers to advance state public health policy. So Pam, I'm going to turn it to you.
Thank you so much, Dr. Waddell, and welcome everyone. It's my pleasure to be with all of you this afternoon to talk about this extremely important topic and would just like to also extend my gratitude and that of the state of Indiana for the CDC Foundation and all of the workforce support that you made available during the pandemic response. We could not have done what we did without their help. And we've even retained 3 of those staff members now through their state funded projects program. So we're very grateful to have them still with us and also to provide some technical assistance for us in our local health departments as we move forward with the implementation of the recommendations of our Governor's Public Health Commission. Next slide, please. So our really where we're embarking here in Indiana is a state investment in public health, and it really such a transformative time for public health in Indiana. In August of 2021, our governor, Eric Holcomb, established the Governor's Public Health Commission and charged it with examining the strengths and weaknesses of our public health system and making recommendations for improvement. We know that through the COVID-19 pandemic, as well as historically, we've had some long-standing, really intractable public health issues in our state. And so our governor really took as we were working through the pandemic response, really took the opportunity to, as we were learning and seeing some of the health issues that had been exacerbated through the pandemic and through looking at our data, really took the opportunity to look at our public health system and say, how can we improve it and how can we improve it together? So our governor put together really a blue ribbon panel and a commission to review our public health system, including local health departments, our Indiana Department of Health, healthcare partners, other community partners, professional associations. And happy to share with you that Dr. Judy Monroe was one of the co-chairs of that commission, having served as a former state health commissioner here in Indiana, and extremely grateful for her leadership with that commission as well. Other co-chair being a former state senator, Luke Kenley, very experienced in working with our legislature and particularly on budgeting and fiscal issues. So this 16-member commission focused on 6 different areas or work streams in reviewing our public health system. And those 6 work streams included governance, infrastructure and services, funding, workforce, data and information integration, emergency preparedness, and childhood and adolescent health, with the goal ultimately to ensure that every Hoosier no matter where you live, in our most rural county or our most populous rural urban county here in Indianapolis, has access to core public health services wherever they live that will allow them to achieve their optimal health and well-being. And we know that we have many, actually we have 95 local health departments here in Indiana, 92 county level and 3 municipal level local health departments that range in size from having maybe 3 to 5 staff members to having hundreds of staff members, such as the one here in Indianapolis. So there are challenges with workforce. There are challenges in being able to provide core public health services or meeting foundational capabilities. And this was truly an opportunity to revolutionize public health in our state. So releasing the commission report, which includes 32 recommendations and around those 6 different work streams, we made a request for legislative funding through our recent legislative session that ran from January through April of this year. Next slide. So with the legislation crafted through one of our legislators authoring the bill, asked for an appropriation to support local and state public health. And that was drafted late last year and then entered into the process in January at the beginning of session. And this request included direct funding to local health departments to provide core public health services. And we requested $100 million for fiscal year 2024 and $200 million in fiscal year 2025. And that was based on a per capita funding formula at $26 per capita, and then additional funding based on challenges with social vulnerability index and life expectancy compared to the state average. So really trying to provide additional funding for those areas of our state, local health departments that really are experiencing some of those public health challenges. We also requested state level funding to support Indiana Department of Health initiatives as well, including regional support technical assistance teams to support our local health departments, expanding our Office of Data and Analytics, workforce planning, and oral health programming at the Indiana Department of Health. Also included a funding ask for emergency preparedness initiatives, such as our state strategic stockpile, trauma system improvement, and emergency medical service readiness and interoperability of communication systems. During September to December of last year, we convened a core public health services committee that included representatives from local health departments and public health partners to define those core public health services that local health departments would provide either directly or through partnerships in their communities if they choose to receive this funding. And I really want to underscore choose to receive this funding. Indiana is a decentralized state in terms of public health governance. And so the legislation very intentionally preserved local control and local approval for this funding. We have 16 statutory and non-statutory core services in 7 different categories related to core public health services. And then we also convened this year a core public health leadership committee to define the state level key performance indicators for each one of those core public health services so we can show return on investment of this legislative funding. Next slide. So bottom line is what passed, and very pleased to announce that we did receive from the legislature $75 million in year 1 with $150 million in year 2 for direct funding to our local health departments. And that compares to $6.9 million that we receive in total historically for about the past 20 years to fund all 95 of our local health departments. So you can see that this is a huge increase in state level funding to support public health. And then we did receive about all of the requests that we made to support our Indiana Department of Health initiatives. We also had 63 legislators sign on to sponsor our bill, again, preserving local control and then defining our core public health services and parameters for the use of funding. Next slide. So one of the questions we get is what were some of the often get is what were the drivers of success? And first of all, I would mention that Blue Ribbon Commission that our governor convened and really his vision to conduct this review of our public health system, showing the data, including life expectancy variations and health disparities, knowing what information that folks wanted, engaging subject matter experts and advocates with our local officials and state lawmakers, garnering support around our state, engaging partners and associations, making presentations, convening meetings, and one-on-one conversations with legislators and elected officials to really explain the importance and impact of public health and the importance of workforce, which our funding will allow local health departments and the Indiana Department of Health to continue to hire individuals to support those staffing teams to provide those services. Preserving local control, as I mentioned, and making sure that our funding is flexible. It is not prescriptive. It can really be tailored to be used to whatever that local jurisdiction needs, leveraging their partnerships in the community, using shared services models, whatever works for them best to provide those core public health services. And then absolutely key is showing return on investment for that funding through budget reports, key performance indicators, and success stories. Next slide. And I think if we have time for any questions or if we need to continue on.
Thank you so much, Pam. We definitely have some questions, and we're going to do that as soon as we hear from Catherine. But so exciting to hear and learn more about what's happened there in Indiana. So now we're going to turn to Dr. Feldman, again, a veterinarian by training, who's currently serving as the Chief Public Health Scientist with the Maryland Department of Health. And Dr. Feldman is going to provide some insights into statewide systems and solutions, delving into how the Maryland Department of Health partnered with local health departments to decrease siloing between state and local health departments, and talk about the ways in which they leverage the staffing from the CDC Foundation to streamline the approaches between the state and local health department. So Catherine, I'm going to turn it to you.
Thank you so much, Dr. Waddell, and thank you for the opportunity to be here today. And also a huge shout out to both CDC and the CDC Foundation for all of the support for our workforce. So I am going to round out this panel by describing very specific implementation of the CDC Foundation funding support for workforce. And so that's what I'll be spending all my time on, but hopefully I can tie it to some of the other things we've already heard a little bit about, like the infrastructure grant. And then I am just so excited to have heard about the Indiana experience, because here in Maryland, in our most recent legislative session, we did pass, I think based on Indiana's lead, a bill to establish a public health workforce commission. And so we are in those early planning phases of standing up the commission now. So hopefully we'll have some exciting outcomes to share at a future summit. So next slide, please. So Maryland is a relatively small geographically state, but a population of around 6 million, east coast of the US. We have 24 local jurisdictions, and I think we're a kind of a blend of a centralized and decentralized state. So those 24 local health departments really vary in being home rule, semi-autonomous, to being under the purview of the state government. But we have a large workforce with our health department and then those 24 local health departments. And when CDC Foundation reached out with this tremendous offer to help support our workforce, we first started thinking about MDH, Maryland Department of Health, where I am positioned, and we set up a plan to make this opportunity available across all of our programs to bring staff in to help support both COVID response needs, but also non-COVID needs. And then we pretty quickly realized that we could extend this to our local health departments just by kind of opening up our mechanisms that we'd established to solicit needs and try to match those needs with potential staffing, with CDC Foundation doing all of the tremendous legwork of advertising, screening, and setting up interviews for us. So through that effort, we were able to bring on, and I've lost track of the number, but tens and tens and tens of staff, both in Maryland Department of Health and in our local health departments. Again, and I think some of the reasons why that was so successful is that we really had a champion and then some support here for that champion. And I'm a self-declared champion for this effort to connect the dots and make it happen both within MDH and within the local health departments. Part of the work was establishing our legal agreements, our memoranda of understanding. And when we did that, we were very conscious to allow staff to be placed in a number of settings. So not just the state health department, but also the local health department, but also other settings such as schools. And so that single agreement allowed us flexibility in putting people in all of these various settings. So really what we did was through existing communication mechanisms, we made the announcement that CDC Foundation was offering to help us bring staff on board, and that almost any job classification would be considered. And so, I think at first people didn't really believe that. But once we underscored that message, people quickly got on board and said, wow, you mean I could get a grants manager for this? I could get somebody to help with equity via this mechanism. And so we pretty quickly grabbed attention. And we were able, again, to support not just our COVID efforts, but our non-COVID efforts, and allow very important functions to continue that might otherwise just not have been able to happen just because everyone was so focused on COVID. Next slide, please. I guess the final thing I'll say about the absolute fabulosity of the CDC Foundation support was the quickness. I mean, I think so many people attending the summit today understand the challenges in hiring quickly. And so not only was it absolutely flexible with the type of people that we could bring on board, it was absolutely quick. It was so speedy. It was almost magical. And so that allowed us to very quickly get people on board and get people functioning. So we had CDC Foundation field staff working in any number of areas, including outbreak investigation, grants management, nursing, school health, health equity, public health accreditation, any number of different areas. And again, that setting, some of the folks working in school health were actually placed in schools. When we talked to the hiring managers for these employees, there was a lot of just kudos, shout outs to the CDC Foundation field employees, really valuable team members. Their involvement strengthened the programs in which they worked. And we just gathered a few anecdotal stories of field staff impact. But one of the big impact stories we had was the CDC Foundation field employee who supported our pediatric COVID-19 vaccine rollout. And I mean, she really did it all. She coordinated within MDH and all of the things that needed doing to get vaccine into our state and figure out who it should go to, but then also with our local health departments, and then also with our provider community, including hosting a kind of a weekly advisory group of pediatricians and AAP representatives to inform what we were doing in the state. We also had impact in other ways by doing a lot of data management and supporting our understanding of what was happening in the hospitals with our COVID-19 patients. One of our grants managers that we hired to help with all of the CDC funding that we received has stayed on now and is helping with the infrastructure grant. And so that has just been tremendous support. We have other CDC Foundation staff who stayed on, who are helping us with our reaccreditation efforts in quality improvement. We have several epidemiologists who've still stayed on and got their start as CDC Foundation field employees. We have an environmental health coordinator. Boy, hiring for environmental health positions can be really tricky. So it was just fantastic that CDC Foundation helped identify a great candidate. And then we have some folks doing some real key work in some of our state priorities, such as diabetes and health equity. And all of these folks came to us initially via CDC Foundation, and we're just so very grateful. So I just wanted to provide that concrete example of how things worked for us, how we were able to make it work not just at the state level, but also to our local health departments through that kind of single point of contact. And then just the flexibility that CDC Foundation provided, as well as the really quick work in getting good people placed in our health departments, really resulted in a lot of success. So thank you again, and that's all I have.
Well, great. Thank you so much, Catherine. So folks, you heard it here, almost magical. Clearly, flexibility is so important to our state and local health departments, and you all figured that out, integrated, worked well together with your partners with the foundation, and really great to hear. So we've got time for questions. We're going to ask that all three of our panelists are on screen, Amy, Pam, and Catherine. So Amy, I'm going to start with you. We've got about 10 minutes for questions. So mental health has been a growing concern for public health over the last few years. And so what do you think public health departments can do to support behavioral health providers and create environments conducive to improving mental and physical health for all of their constituents?
Yeah, that's a great question. You know, I've been thinking about this for a while, having again come from a position where I did work on the CDC side and public health side, and now are working much more with SAMHSA and on the mental health side. From the federal perspective, I think there would be great to have more conversations between SAMHSA and CDC on that physical health side. I do think we all as a nation need to have more integrated care between mental and physical health. We see it throughout everything in our systems, and it affects us. So from the federal side down, some of the work that we did on this this initiative, I've been talking to SAMHSA about and saying, are you talking to CDC? Do you see what they've done with their staffing and what they can do, and how do we work together? Or just to give another specific example, we had here, you might have heard, the Red Hill disaster, as we call it here. And we've had several other natural disasters, and where, depending on where the help is coming from, sometimes there's silos and the divisions aren't talking to each other. So with Red Hill, one of the things that came up out of the EpiAid was a real need for mental health help. And yet it wasn't a first thought to come to the adult mental health division within the Department of Health to talk. So I think that increased communication and understanding that you can support each other, find ways to work together. I think this combined epidemiologist that worked with infectious disease and is working with our adult mental health division is a great way to start to break those barriers. You really do have to build trust. You have to build a communication and find ways that you start to talk, so then you see where those areas overlap and how you can support each other. Another way that we do here in our division, and I think is really helpful, is making sure that all departments of health know that when there are natural disasters or there are other pandemics, that they can go to their behavioral health divisions for help with counseling, for help with support, for some of those needs that often come a little later in the pandemic response or in the natural disaster response. But those are some of the learned lessons. I mean, I think a lot of it comes down to communication. So
absolutely. As you were sharing your response, that's exactly what I was thinking. Is so much about communication and establishing those relationships that we all know are so important. So Pam, let me turn to you. The governor's public health commission certainly is an exciting opportunity to identify the gaps and resources needed to address and advance public health, and work collaboratively with lawmakers to increase funding and support for public health. And clearly you all have been successful in that. And now we're hearing that Maryland's going to have a public health commission. So, let's just keep this going. So can you talk a little bit about really the role of leadership in making that happen. And also, you mentioned that local health departments will have the opportunity to opt out of those funds. So, what happens with those funds if they opt out?
Thank you so much, Dr. Waddell. And in answering your first question, the role of leadership, I think just is so important. And I think really begins with that vision of how do we take a look at what we can do in our state, and then working with pulling the right folks together at the table to really help inform that vision, where we want to go, gathering the data and the information around the areas that we really want to examine with our public health system. And I think that the work streams that were developed for our governor's public health commission, which included workforce, were so key in being able to deliver core public health services, but also the other areas of recommendations in that report. So I think it takes the vision setting, and it started with our governor, with our state health commissioner at the time, Dr. Chris Box, who served as the secretary of the commission. We had Dr. Monroe, we had Luke Kenley, we had former Congresswoman Susan Brooks, who was a citizen advisor, and then bringing the partners to the table on that commission, your public health associations, School of Public Health, local health department representatives, local elected officials, so that we covered a wide range of perspectives. And then gather using folks through our agency to gather the data around that those work streams, because data is so informative, and really getting the lay of the land in your state and taking an honest look at it. And then those people on the commission and through the folks presenting the data, being able to make informed recommendations. But then so critically working with your lawmakers, your legislature and your elected officials to really get the resources and the funding that would be needed to truly implement this well. And making sure that we listen, that we are hearing from communities, and we included 7 listening sessions across the state to hear from constituents all over to inform that work. So from leadership, it plays such a critical role. And then you had asked about if counties opt out of this funding. There certainly is the option to do that. And counties that opt out will continue to receive the legacy funding that they have been receiving all along. So they do not lose money. They will continue to receive the same funding amount that they have been receiving historically. And then if they decide to opt in later on, they can certainly do that. There is no set in stone option, so that there is flexibility. And the county commissioners are actually the ones who opt in or opt out, with the county councils then approving the budgets by the local health department. So again, maintaining local control throughout.
That's great. Well, thank you for that. I know that people will have many questions probably after this for you. So Catherine, in terms of Maryland and what you all have been doing there, did you find through this process that you had more insight into local challenges? And then one of the exciting things about this whole workforce initiative was the variety in terms of types of public health professionals. So I wonder if you could say a word about your use of attorneys, lawyers, and working through the MOUs needed between the health departments and the schools. And we've got about 2 minutes.
Okay, I think the lawyer question, I will put that one second. So in a general way, this opportunity really helped extend the conversation with our local health department. So I would say normally in Maryland, we have a very collaborative daily engagement, especially at the program level with the local health departments. Both the state and the local health departments are needed to provide public health services in Maryland. And so I think most of us generally think of us as all one big team. I think politics were mentioned earlier in the introductory remarks to this session, and I'd say relationships at certain levels might have at times been a little tense over the course of the pandemic. This CDC Foundation opportunity provided another channel to kind of normalize and return to just our basic, we're all in this together. We're trying to provide public health services to our Maryland residents. And so it was another avenue for communication. It was another avenue to understand what was happening in certain programs. And so it was just had those kind of maybe adjacent impacts, but they were so valuable. Working with the lawyers to get the MOUs in place. I don't know that there was anything magical or particularly difficult. I think they appreciated that this was going to really help all of public health in Maryland. And so it certainly didn't get a back burner look. This was coming from very senior leadership at MDH with a big emphasis to help get workers across the whole of the public health environment. And so it got attention, but it wasn't particularly onerous. It's not one of the bigger challenges I remember.
Yeah. Well, wow. Just fantastic. Thank all three of you for sharing those inspiring and practical examples of innovative strategies. And I think from mental health and behavioral health to the collaboration, to the development of Public Health Commission and new funding, to just making sure that we know that we're all in this together, local, state, tribal, and territorial. So thank you so much for joining this summit today. And we're now going to transition to a video. And this video is about the Turtle Mountain Band of the Chippewa Indians' public health journey. It describes the creation of the Turtle Mountain Band of Chippewa Public Health Department. In addition to supporting state and local health departments, the CDC Foundation's Workforce Vaccine Initiative had a footprint in Indian country, providing 76 field employees to 22 tribal consortia, area Indian health boards, and federally recognized tribes across the U.S. This surge staffing support not only bolstered tribal COVID-19 response efforts, but also facilitated public health capacity. This toolkit can be found on the Lights, Camera, Action Summit webpage under Resources. As sovereign nations, tribes have legal authority to self-govern and determine what is needed to strengthen tribal health systems. As a result of the pandemic, 2 tribes identified the need to build tribal public health departments to better serve their tribal members, the Salt River Pima Maricopa Indian community and the Turtle Mountain Band of Chippewa Indians. So we're really pleased to have Stephanie J. in this video share a glimpse of the Turtle Mountain's public health journey.
Greetings, my name is Stephanie J. I am an enrolled member of the Turtle Mountain Band of Chippewa, located in the north central border of North Dakota. Our tribe, the Turtle Mountain Band of Chippewa Nation, is determined to address the health disparities which exist among our people, and we are beginning a journey to exercise our sovereignty and assert our public health authority. During the COVID-19 pandemic, our tribe was faced with many challenges. In October, I believe it was, of 2021, we were introduced to some members of the CDC Foundation, and immediately a partnership was formed. Out of this partnership, we were granted 5 field employees, a tribal epidemiologist, a senior public health advisor, an environmental health coordinator, a community health specialist, and a administrative support specialist. 4 of the 5 field employees were enrolled members of Turtle Mountain Band of Chippewa. And I felt we needed a public health code. We needed to strengthen our data sovereignty. We needed to implement surveillance, and we needed to identify a communication strategy for transparency to our community members. We are the only tribe in North Dakota that provided wastewater surveillance in our community. The resources that were provided by the CDC Foundation provided surveillance, messaging, policy creation, expertise, but above all, hope that it can be done. We can create our own public health units, and our post-pandemic efforts will continue. Thank you.
Well, thank you so much for sharing that video. That's really inspiring to see and to hear. And the word hope is always really something that we should be reminded of, that keeps us all moving forward in a really positive way. Well, now I'm really pleased to move us on to our second panel for today's summit, Partnership and Community Engagement to Improve Health Equity. This panel will highlight how partnerships and authentic community engagement were critical during the pandemic response and showcase the exciting opportunities for developing a resilient, equitable public health system. So I'm really pleased to introduce our esteemed speakers from Alaska, Tennessee, and Puerto Rico. Our first speaker for this panel will be Dr. Ann Zink. Dr. Zink is the Chief Medical Officer for the Alaska Department of Public Health, and she is the president of the Association of State and Territorial Health Officials, ASTO. Now, Dr. Zink is a mountaineering guide, or at least she was, who fell in love with Alaska, so returned to Alaska to practice emergency medicine. It was in this role that she realized the importance of policies to influence and improve health in communities, thus her transition to the Alaska Department of Public Health. Following her, we will hear from Dr. Kimberly Lamar. Dr. Lamar serves as the Assistant Commissioner for the Division of Health Disparities Elimination at the Tennessee Department of Health, leading the state's offices of minority health, rural health access, and faith-based and community engagement. She facilitated the prioritization of health equity across priorities within the department's health strategic plan. And then we'll wrap up the panel with Dr. Iris Cardona, who is a pediatrician and pediatric infectious disease specialist and serves as the Chief Medical Officer for the Puerto Rico Department of Health and as a medical consultant for the Puerto Rico Immunization Program. Dr. Cardona was an instrumental leader during the COVID-19 pandemic response, having served as the Undersecretary of Puerto Rico's Department of Health during that time. So again, each of our panelists will have up to 8 minutes to provide an overview of their initiative, and then we'll have a few Q&As. And so Dr. Zink is going to discuss how the Alaska Department of Public Health established partnerships with community-based organizations in the state to improve health equity with an eye to the role of culturally appropriate communications and establishing partnerships with tribal communications. Dr. Zink.
Great. Thanks so much, Lisa. It's wonderful to join you all here today. I'm actually visiting you from lands in Oregon, but I work in Alaska, and I'm really excited to be here. So I'm going to talk a little bit about lessons that we've learned, particularly with partnering with our amazing tribal partners prior to the COVID pandemic, through and moving forward, and really focusing on that space. Moving to the next slide, Alaska is just incredibly fortunate to have 229 distinct federally recognized tribes. And as we think about health, there's so much that I have learned and we continue to learn from our partnership. As we think upstream, we can really create a more healthy and equitable world, and learning from much of their community, their culture, indigenous ways of life. It's actually a fascinating article that came out recently that was published that showed a closer connection to indigenous ways of life actually had better outcomes from the 2019 pandemic. And so lots to learn here and lots of partnerships. That's been amazing. Moving on to the next slide. I'm going to talk a little bit about history and the importance of history. 1918 pandemic hit the entire world, but Alaska Native people were disproportionately hit, and by some historians' category, was the most impacted communities in the world by the 1918 pandemic. And that lived large in the memory and history of Alaska Native people when the COVID-19 pandemic came about and started to show. I highlight this because history is important, and the trauma from this pandemic really influenced the ways that we responded to the COVID pandemic as it came through. Hospitals like the Dillingham Hospital is built literally in the orphanage from the 1918 pandemic. One of my favorite titles from news articles that came out during this time was Alaska's Remote Villages, A Race Against Time and History. And it was both a chance to reckon with the history of the 1918 pandemic, as well as to take the lessons that were learned and try to do better this time around. So moving on to the next slide, I want to highlight just a little bit about geography and to kind of put a little bit in context. Alaska is actually bigger than Texas, Montana, and California combined. We have more coastline actually than the east and west coast if you combine all of the islands. And here you can see Alaska kind of superimposed. Alaska has a centralized public health structure and has a really unique Alaska Native health structure that makes a big difference in how we actually deliver care within our state. Much of rural Alaska, the only care that's provided is provided by the tribal health system and is critically important across the state. So here you can see on the left, the public health centers that are organized within the state of Alaska, and the Alaska Native Healthcare System referral system with kind of this hub and spoke model, depending on where you specifically are within the state. Moving on to the next slide, you can see here, go ahead, perfect. We have consistently tried to, much of our history is in partnership with our tribes, and building in equity has been a fundamental keystone. We are actually the first state to pass an anti-racism act, and our Healthy Alaskans 2030 goals have been set in partnership with our tribes. So this is not set from the state itself or from tribes. We partner with the Alaska Native Health Consortium that helps to represent all 229 tribes and their health concerns. And so our Healthy Alaskans, and you can check out our website, has these healthy goals that we set out for part of our 10-year strategic plan. And we do this in partnership with our tribes, and we actually have data and dashboards and metrics regarding Alaska Native people health, as well as the state as a whole health, to make sure that we're serving as a roadmap and we're building in that structure early on. This became, if you move on to the next slide, a really important part that we ended up using during the pandemic and thinking about our structure. So when we were looking at how do we distribute vaccines, how do we distribute testing, early on in the pandemic, we were very much stepping on each other's toes. Testing would be sent out to one community from IHS, sending it to ANTHC and then sending it out. We would be doing the same. Many states experience this as well, where HRSA and the FQHCs would be getting additional testing. And so we really were like, we have to build in structure so that we can see where the gaps are, and by identifying areas where we didn't have adequate testing and what testing was needed. So particularly in our most rural parts of the state, it could take anywhere from a couple days to multiple weeks to get one test swab out, even to Anchorage, to then get it to a facility. We had no commercial lab testing within the state. At the same time, our major airline that served interior Alaska collapsed. And so we really had no way to move people and supplies around, including testing supplies. So getting point of care testing, being able to get culturally appropriate messaging out to communities, both physically as a structure, as well as if every tribe has a slightly different community, culture, language, priorities had to be taken into account. And so we really looked at the Healthy Alaskans 2030 roadmap. And when we looked at vaccines, we said, let's set it up in the same sort of way. Let's build in as much equity into our structure that we can ahead of time. And so what we did is we built in our entire vaccine team, a tribal lead and a state lead at every single level. And so here you can see kind of the organization and structure, where we had co-leads between our Department of Health and ANTHC. And then all the way through, including our health equity division, our data, our vaccine distribution had dual leads within it. And what was really great about that is that when the tribes had the option to go with IHS or to go with the state, ultimately every tribe ended up coming with the state of Alaska. And it really allowed us to pool our resources together and to be much more efficient. Alaska, in partnership with ANTHC, then served essentially as almost like Amazon delivery service for vaccines, but then communities could decide on how they were going to distribute it and what that was going to look like. And it was remarkable to see when you provided the resources to our communities to get out vaccines, they just really rose to the occasion. It was the dead of winter. And here you can see pictures of pharmacists and nurses going by dog sled from house to house to deliver vaccines to elders. You can see nursing home delivery. This woman here who's got this great big smile on, she said, unlike the Great Death, which is how many people have referred to the 1918 pandemic, the great illness of COVID-19, we have tools to respond. Here on the top corner, you can see where communities would go out and basically fly in small plane to all of these different villages. Community health workers would come up via snow machine, get vaccinated on the runway, and be able to move to the next one. And how this looked in our most northern areas versus our tribal coastal regions were all very different. And so Alaska, as a state entity, really just try to enable and empower communication, distribution, visibility early on, and then really get out of the way for communities to do the really important hard work of delivering in community in the ways that was going to make the most logistical sense, given the logistics of the environment, as well as kind of culturally relevant and appropriate ways. Moving on to the next slide. Communication was a big part of this as well. And so lots of partnership with our community partners in multiple different languages, including one community still has standing orders for what are referred to as breath catchers, given the translation, as well as, and in many states did this, but how do we make sure that we take culturally relevant values and create messaging that is consistent? So more of our Southeast region, thinking about boating and fishing and what that looks like versus more of our interior with the muskox, protecting our elders. They cared for us, let's care for them. Became really challenging with messaging such as washing your hands. You know, 32 communities with inadequate running water and sewer. And so making sure that messaging was tailored to the sewer and water capacities within communities. And it may be doing VHS radio conversations with whaling captains in the northern portion of the region versus southern portions. Moving on to the next slide. Those unique geography and challenges we continue to lean into. So how can we use geography to our advantage instead of our disadvantage? Moving on to the next slide, you can see here that we've really started to prioritize the ways that we can lean into partnerships, making sure that we're sharing priorities and gaining perspectives from different community-based health organizations and tribal health organizations, and making sure that we've got the informatics and information needed so that we can get the data to understand where we see the inequities. We can share information in culturally relevant ways so that we can address inequities. Moving on to the next slide, you can see here that there's a big focus right now in the state of Alaska to building in to our system because that's what we really found during the pandemic and prior. If we can build in voices, particularly from our tribal partners, this is what we're doing with Medicaid redetermination right now, then we can have better outcomes in the long run. Moving on to the next slide, you can see that part of this is thinking about how we make sure that behind every decision, we're building in that whole person response. And moving on to the next slide, there's a couple examples of how we're trying to take our healthy and equitable communities infrastructure dollars and looking at that and how do we use that for things like health-related social needs waivers from CMS to be able to kind of build in these equity structures. Moving on. Seeing on the next slide, you can see the Fresh Start campaign, which came about as part of how do we have these inequities within our systems? How can we build in prevention? And again, how can we then take that and move that towards both public health and healthcare system? So we don't have two separate systems, but we have one system that's really providing health. So moving on to the next slide, I just really wanted to thank everyone for being here. Medicaid redetermination is another component of how we're thinking about these slides. I usually end with this slide because we all have our hands on this system together, be it public health or be it healthcare. We have amazing people who are holding it, and we are all serving the community as a whole. So thank you for the opportunity to provide a little bit about tribal health, and I will turn it over to the next speaker. Thanks.
Right. Thank you so much, Anne. Really a lot of great information there in terms of, you know, the structures and the importance of thinking proactively around structures and policies and the integration that needs to happen. So now we're going to turn to Dr. Kimberly Lamar. She's going to provide an overview of the Stretch Initiative, describing what the CDC Foundation staff helped them to accomplish and how to leverage resources for a common goal while connecting and growing capacity in local communities. And again, Dr. Lamar serves as the Assistant Commissioner for the Division of Health Disparities Elimination with the Tennessee Department of Health. So Kimberly, to you.
Thank you, Dr. Waddell, and thank you to the CDC Foundation for allowing me to share with you today. I'll put a little bit of this into context relative to the state of Tennessee. And so Tennessee consists of 95 counties, 89 of which are really considered rural counties. And so the state as a whole has purview over those 89 counties. The remaining 6 counties are under the leadership of the local government there. And so bigger cities like Memphis, Nashville, and Johnson City, say for instance, in East Tennessee, are all considered part of that local government infrastructure. And so, like many states, Tennessee, prior to the pandemic, was experiencing workforce shortages. And so you can imagine what that was like going into a pandemic. My division specifically, going into the division, my division is consisting of 3 offices. And so you have minority health, rural health, and then we were able to create a new office during the pandemic for faith-based and community engagement. But within my office, we started off at the height of the pandemic with about 14 staff. And so our office was tapped from the governor's office to be that entity that led all of the vulnerable populations initiatives. And so having a team solely of 14 staff, 4 of which included myself, were responsible for really doing the majority of the outreach engagement and kind of going through the process of making sure that we were connecting to communities. And so very small team. And so we are very, very appreciative of the CDCF support through this initiative to be able to help us with, for one, building the infrastructure to be able to do the work, but then again, to build the capacity for us to be able to address pre-existing disparities, but then to again move toward prioritization and other initiatives beyond COVID. So part of our team, again, I started off with 14 staff, and throughout the pandemic led me to about now currently having 31 staff members on my team, most of which are CDCF assignees. And within that, we were able to retain all of those staff persons currently on our team. And so it's been a huge support to do that. And so this team has been critical to us being able to address, again, vaccine equity across the state. We hired a number of community outreach workers, which we have since started the process of training them into community health workers, which adds to that sustainability of those workforce. And so they were critical to engaging communities. Again, we're vulnerable, we're a majority of vulnerable populations, but also the rural populations where limited access to electronic resources, broadband was a challenge, all of that. And so when we have our communications going out through social media, internet, it was really, really challenging for many of our smaller rural counties to be able to access that information. And so what we had to do was build a team of outreach workers that were able to engage at the local level, knock on doors, go into the communities, and really be able to share resources and information and bring all of that to those communities that were disconnected from many of our electronic resources. And so that team is still in place, is growing, and it's been truly an asset to us being able to sustain that work. Also, we have assignees that have been able to allow us to really build that provider engagement support around vaccines. And so really to be able to really go into many of these smaller practices, into our safety nets, and really talk to providers in that space about the importance of vaccines. And so that was really important in order to build that access across the state. As you can imagine, many states had challenges with the trust and all of that relative to wanting to deliver those vaccines. And so that team was really critical. And then our ability to utilize data to understand where we needed to go, to understand where the most vulnerable individuals and communities were and where that need is. So looking at data such as the Social Vulnerability Index and all the local data that we had relative to COVID cases and hospitalizations and deaths, and being able to really synthesize all that data to allow our outreach workers to really have a focused area of where to go. And so again, all these initiatives are all still in place. And so moving all of that work for COVID and for vaccines is still actively engaged, but also being able to use that infrastructure to move us beyond COVID into continually addressing disparities, COVID-related disparities that put our most vulnerable at risk for being a case or death or dying from COVID-19. And so looking at issues such as, again, chronic diseases and mental health, those are two high priorities for the work of my division and the work of this team that we continue to engage. And so I want to talk a little bit about the Stretch Initiative. And so what we can appreciate about the Stretch Initiative is that the Stretch Initiative allowed us to really look at our internal systems and infrastructures, programs and processes, right? To understand how we can move to advancing health equity. The Stretch Initiatives allowed us to look at the root causes and allowed us to create a plan, which we have been engaged in the planning process for the last 2 years. To understand where we are needing to kind of break down silos and integrate and collaborate across the Department of Health, but opportunities to change and look at how we deliver programs that are making the most impact on the communities that we serve. And so Stretch, the team that we built has been a team that is really interdisciplinary, that really represents every division and office across the Department of Health. Also bringing in some local resources, as well as I want to give a shout out to our CDCF assignee. Her name is Dr. Melody Princess Kelly. Being able to hire her and allow her to really lead this work, and really be able to build relationships, really leading the planning, the implementation, the design of the roadmap, which we call it the roadmap, and I'll share a little bit about that in a second. She's really been critical to us being able to get this plan off the ground and going. And so I do want to recognize her and her work and working with the CDCF and all the resources that were able to be provided to us to allow us to move this initiative forward. So next slide, please. So what we were able to do through the Stretch Initiative was to be able to build what we call the Health Equity Roadmap. This is our roadmap for being able to advance health equity. It's a 4-phase leadership-led initiative that we're in phase 2. And so our roadmap consists of us being able to, again, first look through preparation and planning, and that is us being able to create a team, which we call the Health Equity Advisory Team, internal to the Department of Health. Again, that's that interdisciplinary team that we have. Us being able to move toward learning and us being able to have a shared common language across the department. And so when we talk about disparity or we talk about social drivers of health, everybody's on the same page in terms of language. And then for us to then move into the next phase, which we're moving into now, which is the implementation phase. That is looking again at our programs, policies, procedures, and how those are either meeting the need of the community or there's opportunity for improvement, and us being able to make those changes to do a better job at implementing. And then our last phase is maintenance. How do we go back and monitor and look at our data and how we've been able to make those changes and the impact of those changes, and then being able to adjust from there. And so we've been able to, again, really work with our leadership and have that support to be able to move all these initiatives forward. And we could not have done that without the support of CDCF. And so, again, we're grateful for the support. We're grateful for this initiative, and it's truly made an impact both during the pandemic and long term for our office and our agency. So thank you again.
Great. Thank you so much, Dr. Lamar, for sharing that. And really great to hear that you've been able to not only get additional infrastructure, but sustain that infrastructure to do the work there in Tennessee. So I know we'll hear a little bit more about that in just a moment. So now we're going to turn to our final speaker for this panel, and that is Dr. Iris Cardona. And Dr. Cardona is going to describe Puerto Rico's health equity approach in testing and treating COVID-19, including the importance of changing the service delivery system to meet the population's need. And again, Dr. Cardona is a pediatrician and has served as the Chief Medical Officer for the Puerto Rico Department of Health. So, Dr. Cardona.
Thank you, Doctor. Thank you for having me and for the space to share Puerto Rico efforts with COVID-19 therapeutics and testing. Moving to next slide. Puerto Rico Department of Health Therapeutics team is a multidisciplinary team working together on the development of standardized protocol, culturally appropriate educational materials, and database to allow early adoptions of COVID-19 therapeutics that are under EUA in Puerto Rico. Antivirals, Paxlovid and Molnupiravir arrived to Puerto Rico by the last day of December 2021 and were first allocated to 25 Walgreens pharmacies, but we managed to expand to hospital pharmacies and independent pharmacies here. We conduct a strategic analysis using the CDC Social Vulnerability Index and municipal COVID-19 positivity rates to quickly manage antivirals available, prioritizing municipalities at high risk with limited access and high positive case rates. Today, Puerto Rico counts more than 500 pharmacies across all 78 municipalities here available to dispense oral antivirals to eligible patients. Our pharmacies are located within hospitals, federal qualified community health center, local clinics, independent pharmacies, and chain pharmacies that also provides home delivery service for patients with transportation limitation or other barriers. It is important to say that we also managed to establish a hurricane emergency preparedness plan to ensure access to COVID-19 treatment during any emergency that might cause interruptions of oral antiviral distribution. Next, as we go into our Test to Treat initiative in Puerto Rico, in December 2021, Puerto Rico faced a record high positivity case rate on the first Omicron surge. We collaborated at that time with the National Guard and one hospital, Hospital Ramon Ruiz Arnao, which is located in Bayamón, Puerto Rico, to establish the first Test to Treat location. This site is a 5-step drive-through and walk-in clinic that offers one-stop shop for testing and treatment for all patients, regardless of their economic capacity, insurance coverage, or immigration status. Symptomatic patients can visit our site and get tested. While awaiting results, they are oriented on the current treatment option. If they test positive, a physician is on site to clinically evaluate the patient for treatment eligibility. All eligible patients leave our site with treatment and are called for a telephone follow-up 7 to 10 days later. You might ask why 7 to 10 days later for a follow-up call. This ensures completion of treatment and patient feedback on adverse reactions and treatment effectivity. Our main Test to Treat sites, you can see the photo in the slide. URA has completed more than 25,000 COVID tests, found more than 13,000 positive patients, and more than 12,500 patients were linked to treatment. As President Biden launched the Test to Treat program, Puerto Rico Health Department collaborated then with HRSA and Federal Qualified Community Health Center to establish 20 additional Test to Treat sites across the island, including one in our remote islands of Vieques. Next, please. Education, capacity building, and expansion are our three main strategies to ensure access to COVID-19 therapeutics across the island. Starting with education, I can say Remember, the predominant language spoken on the island is Spanish. Therefore, our team works quickly and effectively on the development of protocols and culturally appropriate educational materials to ensure knowledge on treatment options by our population. On capacity building, over 117 educational training courses have been developed and shared across all audiences, from healthcare professionals, community leaders, public health staff, and the general public. On expansion, over 120,000 oral antiviral courses have been dispensed, and over 118,000 monoclonal antibody treatment has been administered in Puerto Rico. Our team continues to onboard pharmacies to ensure access across all municipalities. Next, please. I want to share that we were very successful in achieving the goal to get COVID vaccine in the arms of our people. I think that our ability to create partnerships and collaboration is what makes the difference. Puerto Rico Department of Health ensured the availability of an adequate network of trained and technically competent COVID-19 vaccination providers, more than 900, that understood their role and deliver very creative ways to vaccinate. Locations were diverse. You can see we have traditional and non-traditional immunization sites, hospital, community health centers, physicians, clinic, dialysis clinics, but additional settings, homebound, embassies, airports, school, industry, banking, supermarkets, drive-through settings, homeless shelters, daycare centers, beach, hotels, church, among others. Locations, as I said, were diverse and vaccination phase progress. Almost in every corner in Puerto Rico, vaccines were offered. Finally, I want to recognize the magnificent work done by the immunization and the therapeutics teams here in Puerto Rico. We have CDC Foundation staff embedded in Puerto Rico Health Department and specifically assigned to work directly with the Chief Medical Officer Office. CDC Foundation fills critical staffing gaps that we have, and we really appreciate their support. Thank you. I will be happy to answer any questions.
Thank you so much, Iris, for that amazing presentation. So we now have all three of our panelists, and we've got about 10 minutes for some questions. And I think I'll start with you first, Dr. Cardona. Well, maybe we'll go in reverse order for this one. But you had an amazing slide there that really identified all these different partners and all these different types of sites. And so what you were able to accomplish there in Puerto Rico is an incredible example of the power of partnerships. I wonder if you could also mention a little bit about some of the mobile clinic work that you all have done and how that engaged the community and worked with various partners.
Mm-hmm. Okay. We have some lessons learned in all this process. I can say that we need to be prepared, and we also learned that collaboration between all sectors and service is the most important tool. Public and private partnership might allow to leverage resources. And then trust is crucial. So we have to manage to communicate effectively with all the public, but also with all the service delivery here in Puerto Rico. Finally, my final comments: vaccines are powerful tools. We have a strong history of immunization here in the island, and we are a small island in the middle of the Caribbean. So in Puerto Rico, everyone knows everyone. So it was not easy, not that easy, but some easy to make strong collaboration, and relationship with every hospital. For example, in the immunization campaign, when vaccines arrived to Puerto Rico that December 14, we assured that every hospital in the island start immunization their staff at the same time, the same day, December 15, 2020. I think that was an amazing achievement. Talking about mobile clinics, they are great interventions because they let us flexibility where the patients can receive care and also address community and social determinants of health. They are not new in our environment. Remember, we are in the Caribbean. We experienced Hurricane Irma and Maria in 2017. And after Hurricane Maria, in Puerto Rico, Federal Qualified Community Health Center in La Montaña, a partnership with the Children's Health Fund, and support extraordinary efforts with mobile clinics to serve children and families in the rural communities here. That experience was seen again in 2022 with Hurricane Fiona. And that was the strategy used by our immunizators for the rural areas in Puerto Rico. We have a program called Health Department Goes to Your Home. Puerto Rico Salud Visita Tu Casa to immunize homebound population in rural areas in Puerto Rico.
Okay, well, great. A lot that folks I know have learned and will continue to learn from you all there in Puerto Rico. Well, Kimberly, your department in Tennessee has done a great job of initiating and engaging communities as part of the solution. Can you describe a little more about how you've empowered local communities and community-based organizations in improving health outcomes for their communities?
Sure. And so just a little bit about, you know, our modes of communication throughout the pandemic. And so early in the pandemic and the emergency response, we had an immediate need to get information to communities. But what we had in place, as I mentioned earlier, was really a one-directional mode of really putting things on social media and expecting people to go out and access that information. But again, we're challenged with again, broadband access and a lot of other ways that we're challenged with getting information out and understanding what communities need. And so early on, we knew that we needed to create a bi-directional feedback mechanism. And so what we did was we created our Health Disparities Task Force. This task force still engaged as to date. We created it early in 2020 to be able to get information out, but also to be able to receive information. And so with the help of our community outreach workers, we were able to identify and recruit from all over the state, whether it was our urban community and our rural community, and get them engaged in the process of being able to tell us what was needed in the community, so that we were able to execute and get information and resources out based on what those needs were. And so again, we have a Health Disparities Task Force that currently, it started off with about 50, 70 individuals regularly engaged to right now, a little under 2,000 individuals from across the state engaged on the task force. And so what we're able to do is partner with our local academic institutions, and that's, you know, from K to 12 to all of our colleges and universities. Medical schools are also on board on the task force, but also our faith community. Faith community was huge to get information out, because if you know Tennessee, there's a church on every corner in every community. community. And so engaging our pastors and our faith leaders, was critical to being able to reach everyone in those neighborhoods. And so the churches were critical there. But our nonprofits, other organizations, our local leaders, whether it's the mayors, the governor's office, our local representatives from the legislature, all getting together on a regular meeting to talk about what's needed, and then two, to utilize all those systems to get that information out. And so you had nonprofits who may have food resources, or they had clothing, or all these resources were available. It's just, how do we coordinate that effort? And that's what we're doing, and that's what we've done through that task force. The task force has been critical to also allowing local level leaders, those that live, worship, work, and play in those communities, to create their own solutions. And so what we don't want to do as a Department of Health is tell them what we think they need to do and what we think they need. We really need that level of engagement to come from that local community, and we just serve in a role of supporting that, whether that's financial. We were grateful to receive funding through our health disparities grant, the COVID-19 health disparities grant, a little under $38 million that we received to be able to implement those local level strategies. And so whether that's funding our nonprofits, and we have about 200 partners actively doing projects across the state, which is huge. And all of that stemmed from the Health Disparities Task Force, and that all of that initial engagement. Again, we're still going forward. We're creating all kinds of opportunities statewide.
Right. Well, thank you so much, Kimberly. And so I want to make sure we give the final word here, if you will, for this panel to Dr. Zink, who's not only representing Alaska, but as the president of ASTO. And can you talk a little bit about how leaders effectively communicate the importance and prioritize community partnerships to address disparities? All of you all have talked about structures and systems. And so as we wrap up this panel, I think that's an important lesson that we want to make sure comes across too, that in order to really address equity, then we have to ensure that we're addressing those underlying systems and structures. So Dr. Zink, what else would you like to share with this panel?
Yeah, that is right along what I was going to say. And I just really want to elevate what both, Iris and Kimberly brought up about building in structures of equity prior to a challenge and creating places for two-way dialogue and communication. This is not public health doing. This is not us telling. This is creating two-way conversations to know what a community needs and wants, be it a faith-based organization, a tribe, a local community. Is it a mobile integrated team that needs to respond? What does a community need? And creating a synergy for two-way education and structure. So we sometimes joke about, we'll be here before you and we'll be here after you. Let's make sure that health equity is built in before us, so it's here after us, and that we've got the data and information, and that we're constantly thinking about listening as much as, if not more than, talking, so that we can empower communities because they know what's best for their community. We all want sovereignty. We all want ownership over our own health. And really, as public health professionals, we owe it to our communities to listen and to serve. Thanks.
Fantastic. Well, thank you to the panel. Thank you, Anne, Kimberly, and Iris, for your leadership, your inspiration, and your examples of what was done, what can be done through partnerships and community engagement to achieve health equity. So we need to listen, we need to hear, we need to engage. So thank you all so much. Well, now I'm going to invite us all to take a look at this next video. Last summer, the Workforce Vaccine Initiative asked staff to share what they were most proud of during their time on the project. This next video, called Most Proud, features 4 former Workforce Vaccine employees reflecting on this impactful work conducted in public health settings across the country. So let's hear from some of our team members.
Hello, my name is Lily Hughes. I'm a budget analyst for Region 4 here in Tennessee. It is easy to focus on the numbers as I do every day. Therefore, what I am most proud of from my time with the Workforce Vaccine Initiative is being able to see firsthand all the hard work Tennesseans are doing to assist in the COVID-19 education, vaccine outreach, and confidence building activities across the state. It's been said, we're better together, y'all. Thanks for this opportunity.
I am most proud of the relationship that we have built with our state jurisdiction and the way that we have strategized and made sure that the positions that we were hiring for, that they would become a permanent part of Ohio's public health workforce. That relationship has been just so inspiring to me, and I'm glad to be able to make a difference. I'm also really excited for our team members, our field employees. They inspire us every day with the great work that they do. We love to see them progress as public health professionals and also cheer them on in their next phase of their career.
Hi, this is Catherine with Wisconsin DHS, and I am proud of leading a team that has addressed over 3,000 COVID-19 vaccine inventory and data quality related issues with the Wisconsin Immunization Registry.
Hello everyone, my name is Bosco Orenga. I was born in South Sudan. I spent few years in Uganda before moving to the United States. I am an epidemiologist assigned to Maryland Department of Health in the Division of Outbreak Investigations. What I'm most proud of with my time here at CDC Foundation is knowing that the work I do does not only impact the community I serve, but the entire world. COVID has taught us how interconnected our world is and the need for proper public health interventions. Thank you.
So for those of you that joined us later in the program, I'm Judy Monroe, President and CEO of the CDC Foundation. And I want to thank you again, Dr. Waddell, for heading up those thought-provoking discussions, and to our panelists for their very informative presentations, where you heard about innovations in public health infrastructure, as well as how to improve health equity through partnerships and community engagement. So now I have the pleasure of leading our next discussion, where we'll consider the innovations and strategies shared earlier, as well as how the pandemic can serve as a catalyst for change. We have with us three outstanding public health leaders, thinkers, and doers. So the first is Dr. Anand Parikh, who serves as the Bipartisan Policy Center's Chief Medical Advisor. Next is Dr. Brian Castrucci, who is President and CEO of the De Beaumont Foundation. And we're also pleased to welcome Carolina Luna Pinto, who serves as CDC's Acting Director for the Office of Minority Health. So I'd like to start the conversation with a question for you, Anand, if we can get everybody on screen. And then I'll encourage Brian and Carolina to join in, and we'll do that with each of the questions. I'll call on someone primarily, and then the other two chime in. So first question, our nation's public health system faced challenges for decades heading into the COVID-19 pandemic. So we came in a weakened state to begin with. But after more than 3.5 years since the start of the pandemic, what do you see as the top 3 policy changes that should be implemented to improve our nation's public health system going forward? So Anand?
Judy, thank you so much. And first off, let me just congratulate you and the CDC Foundation for putting on this summit. Such an important topic at such an important time. So thank you. That's a tough question in terms of 3 sort of most important policy changes. I will say that at the federal level, Judy, that there are going to be some constraints in the short term. And, with the recent debt ceiling agreement, there are going to be fiscal constraints in terms of discretionary spending, caps on that spending, flat funding. So even though there are pieces of legislation such as Senator Patty Murray's Public Health Infrastructure Saves Lives Act that really tries to get at that funding gap for foundational capabilities in the United States, those opportunities are going to be difficult in the current environment. There are a couple pieces of legislation, reauthorizations, that have to occur at the federal level on a bipartisan matter. The Pandemic and All Hazards Preparedness Act needs to be reauthorized this year. That focuses on all hazards preparedness and involves public health departments, perhaps data authorities, and issues related to public health data infrastructure could be integrated into that. There's a support act that needs to be reauthorized that focuses on the opioid epidemic. There are public health department connectivities there, but these opportunities, unfortunately, are going to be few and far between. And so I think the way I'd answer your question is with policy with a small p. So what are three things that I think really ought to be happening right now and in the near term? And this is going to be less the sort of Congress and what's happening in Washington, D.C. But the first is to reiterate what Patty Simone said at the outset of today's summit. The best way we can make the case for long-term sustainable investments in public health is to do the very best job we can do to implement this $3.9 billion public health infrastructure grant coming out of CDC. And myself, Brian, and many other public health leaders about a year ago put together Public Health Forward, which is essentially a 5-year vision for governmental public health in the United States with an actionable framework for local and state public health leaders and elected officials. I hope that every jurisdiction really takes a look at that as they implement the public health infrastructure grant. So I would say that's sort of the first action. I think the second is what Pam from Indiana alluded to, and Judy, you had a big hand in this. I think federal leadership is important, but state leadership is critical as well. And the more states that can emulate what Indiana has done, a very open, transparent, data-driven, bipartisan process to galvanize stakeholders as well as policymakers on both sides of the aisle to really increase public health funding at the state level is just a tremendous success. And it's so nice to see both blue and red states, Maryland, we heard today, others interested in that. So we need to really replicate that as a second. And then as a third, I would say we need to double down on partnerships. And we've heard a little bit about that today. Public health at the end of the day is all about trust, whether it's businesses, faith-based organizations. I'll borrow from Ann and say that I think healthcare, we've talked about healthcare and public health partnerships for a long time. We have an incoming now new CDC director with healthcare experience. It is time to leverage the over $4 trillion we spend in health in this country. The majority of what goes to healthcare, not public health. It's time to leverage for workforce purposes, for data purposes, for community benefit, nonprofit hospital spend. There's so many ways we can leverage the healthcare system to strengthen the public health system. And so I think we need to double down on partnerships. So I would say in the short term, in terms of advancing public health, it may not be in the traditional sort of policy or federal policy or action that we're accustomed to. But I think that some of these actions that I've articulated and that others during the summit over the last several hours have talked about, I think that's a really important way forward.
That's a great answer. Thank you. Thank you. Brian or Carolina, you want to jump in on that question?
Sure.
Yeah, on the policies,
sure.
yeah.
Yes, so thank you. I just wanted to add, I think definitely on, agree with the part about the public health infrastructure and how do we demonstrate impact in using that. And we currently also have the health disparities grant, which is, will be sunsetting next year. And so, I know that within our Office of Health Equity, and with Patty's, center infrastructure center, we're looking at how do we leverage what jurisdictions have done with the health disparities grant, some of those systems, some of those structures that have been put in place, like several of the examples that were discussed here, can continue, with the public health infrastructure grant and expand on those. And that is one critical area, I think, that where we could show that, sort of that blending and braiding and how can we, continue and show that impact from, moving along. And I think that would help also to sustain some of the positions, that we've heard that were critical, that were, hired and critical, hired during the pandemic, through the foundation's initiative. And then, those positions have been able to continue on. Well, how do we do that with, as we continue this funding? And hopefully, I think with the looking at some of the, how could we look at the state's funding? And I think we had a great example from Indiana, how could we leverage that funding so that everybody has, sort of a piece of the pie, or, you know, that sort of thing. Thanks.
Yeah, and I think, you know, with Indiana, I mean, they really have built in the accountability, just as with the $3 billion at federal level and the funding going to the states. Indiana's going to have to prove in the next couple of years. They're going to have to come back and show that return on the investment that the legislators made. So it calls on all of us to do that. Brian, any comments on that?
So
question?
I'll just come out of my corner swinging. Let's just start with eliminating MD requirements for non-clinical jobs in public health. Let's start there. There are far too many people who enter a career in public health only to find that the leadership roles require a degree that is not public health. And so while I think for a chief medical officer, you probably need an MD, health commissioner doesn't. There are far too many leaders in public health who are on Monday serving in a primary care clinic, and on Tuesday heading up a multi-million-dollar agency with staff, and they've never had that experience. We have to stop hiring leaders for technical expertise and hiring leaders who can lead. That's number one. Number two, I agree with Anand. State leadership is super important. You can't win a war when all the generals are at odds with each other. And that's the thing that Patty didn't mention today. I love the infrastructure grant. That's great. But that infrastructure grant went to states that were antagonistic to COVID, that were antagonistic to governmental public health. You know, maybe there's a state with, I don't know, a nice theme park and some coastal area. They're getting infrastructure money, even though their health commissioner was outed in a newspaper for manipulating data. So what kind of hope do I have of rebuilding a public health system when there are governors who opened restaurants and bowling alleys at the height of the pandemic? And lastly, the business community. We have to engage the business community. That's who I'll never forget when several business leaders penned an op-ed, I think to the New York Times, that asked President Trump to do something, and he did it. He's not going to listen. I like y'all. I like Anand and Carolina. You seem really nice. Judy, I've known you a real long time. They're not going to listen to us, but they're going to listen to business leaders. And so we need, as public health leaders in our communities, we need to know the 3 leading causes of mortality. We also need to know our 3 largest employers, and we need to engage them.
Thank you, Brian. Yeah, I would only expect you to come out swinging. So thanks for that. So Brian, I'm going to stick with you. What do you think is being done and can be done to recruit more talented and diverse workers to public health and to retain and develop our talent?
So we published a study in Health Affairs that showed that between 2017 and 2021, we lost 50% of our workforce. When you look at the 35 and under group, we lost 75% of that workforce. The net is gone, right? We used to have a net and it's not there anymore. And so we're on the trapeze, and if we make a misstep, we hit the earth and probably don't survive. That's where we are right now. And we can talk a lot about workforce recruitment and retention, but really the challenge is we have 3,400 different public health departments with different systems and different hiring processes. And so we have to figure out what we can do at a national level to help drive this. Maybe we do need a national public health corps similar to what CDC Foundation deployed during COVID. Maybe that needs to be active at all times. Maybe we need to invest in loan repayment. But we also have to think about, are we just rebuilding on the same broken system? Right? So you can't recruit and retain into something that is inherently broken. And we can't just magically wave a wand and have salaries go up. And for all the wonderful presentations that we saw today, they are somewhat unique in that each is in a different context. We need to find ways to make the system better and stronger. We need a national public health vision from all of the governors, Republican and Democrat. We need alignment. We need to have a chief public health liaison, a chief public health community health liaison in every single health department, someone from the community with lived experience, not that we've engaged, but for whom we've made space at the table. And every single health department needs to have a business council. If you don't have regular and consistent communication with the business community, we're not going to succeed. And I think that was true during COVID as well. There were far too many places in this country where The health commissioner met the head of the Chamber of Commerce for the first time. They introduced each other. They say, that seems like a nice person. Then the health commissioner said, oh, by the way, I'm shutting down the economy for a week. That is an awful first date. No one is swiping right after that kind of first date. And so we have to talk to our business community at all times and understand what's going on in their mind and how we can work together, because every business is a public health entity, whether it's the health of their employees, their consumers, or their community impact. We need to leverage that going forward. We have to support our public health workers, but it's really hard to do when we are like the living embodiment of the Tower of Babel. Every single health system does its own thing.
Yeah, no, well stated. We really do not have a coherent system, as you're saying. Carolina Anand, response or additional thoughts on that question?
I'll just say that I think it's a very good step that the current CDC grants are requiring a workforce director and working with the public health department, understanding and leading efforts related to recruitment and retention, I think are critical. To Brian's point, I think it's got to go beyond the public health department. I think there has to be a case for how this connects to the governor's plans for reviving a state's economy, for job growth, how public health connects to the economy, how this is a part of job growth and job creation in a state. And so I think public health has to sort of insert itself into that equation and be at the table there. And I think that's why it's got to go beyond just the public health department, but to really the policymakers as well as the leaders of the state.
Yeah, and I would just, that it really calls on those relationships. It's not going to happen without the relationships with business, relationships with the legislators, with the governors. So it really does call upon public health leaders to get out there. It's an active job. It takes a lot of energy. Carolina, any other thoughts on that one?
Yeah, I was just going to mention, being in Puerto Rico and the Virgin Islands, after Hurricane Maria, and then through that recovery process, one of the things that we learned, so beyond the workforce director, which is great, that's being required, was having a unit that was responsible to manage all the funds. So, the amount of funding that was coming into the health departments was much larger than they would, typically receive. And it hit all of the parts of the health department. So it required a lot of coordination and, federal funding, and also leveraging so that they weren't, duplicating or, hiring more people for something that, maybe it could be a combined job and that sort of thing. And so, and I'm happy to report, and I know Dr. Cardona was on earlier, that unit or that sort of model has been institutionalized at the health department in Puerto Rico and somewhat in U.S. Virgin Islands. And it has helped them be able to continue to have that sort of central coordination that reaches out to the various parts of the health department for the funding, so that there is that leveraging. And the other piece I just wanted to add on was in terms of, making that connection with the governor. I know that in Puerto Rico and U.S. Virgin Islands, it's very connected. It's very, very close, that relationship with the governor and the health department and what's going on. And, one of the things that we've seen recently, and you all have mentioned it, is, this concept of divisive concepts and divisive policies. And so how are we as CDC going to address that? I think that's a big concern for us right now, sort of, with funding, that is addressing health disparities. How do we do that? So just wanted to add that.
Yeah, no, thanks for that. Yeah, I mean, after Hurricane Maria, certainly Puerto Rico had to rebuild its public health infrastructure. So anything else you would add in terms of advising your colleagues in public health about what they need to do to rebuild and prepare for whatever might come next? from your experience in Puerto Rico? Anything else you want to add?
Sure. Yeah. I mean, I would just say that, in those two, in that instance with Puerto Rico and USVI, they are in a geographic area, right? That was mentioned, that is, they're prone to, these types of disasters, and Hurricane Maria being one of those, disasters that happens once in 100 years or something like that. And so their structure was, a public health infrastructure for both islands was completely devastated. And I think, having lived through also other, situations as Zika and chikungunya before, and then moving into the hurricane recovery, they then joined, the rest of the world with the pandemic situation. So, but they were already sort of dealing with this over and over and over. So they deal with this cumulative or sort of cascading effect of, impact to the public health system. And so I think they have learned, to be able to learn from what's happening before, what structures can we put in place and quickly respond to what's happening. I think the other piece is having that close relationship with federal agencies. So in the whole recovery process, which is still going on, right? There's, FEMA and ASPR and other federal entities that, work, closely with the health department and the governors. And so I think there is a lot of alignment there, even though there's a lot of, issues with processes and, how that system works. But I think that having the experience of having to rebuild, and then also work with, with CDC in terms of, how do we sustain the laboratories, for example, how do we make sure that they are, up and running? How do we make sure that immunizations are, out, we're able to either, reposition, that sort of thing. And, you heard earlier from Dr. Cardona, that they keep tweaking, that emergency response plan, which is not just, to respond to one event, it could be multiple events at the same time. And so I think that's something that I think other jurisdictions can learn from Puerto Rico and USVI, that they, had to sort of look at things from multiple levels.
Yep. Very good. So an audience question. How can public health prove effectiveness to legislators, particularly legislators representing largely rural districts, if the rural morbidity mortality penalty persists? So that's the first part of the question. And if rural health disparities and inequities persist that rural voters are all well aware of, how can public health overcome decades of mistrust? So it's a two-part question. Brian and Anand, you guys which one of you want to jump in first?
I'll start, and then Anand can do the more civilized bipartisan response. This has to become a platform of the Republican Party. We are chasing our tails around drag queens and transgender care, when we really need to be recognizing that those places that Republican legislators come from have this rural challenge, this rural penalty, as the audience member said. And so that's what we need to be talking about. This is why it was harder for rural America during COVID. They've closed down the primary care clinics. The hospitals are leaving. And remember, that money that Patty Simone talked about, all those jurisdictions were either states or, I believe, jurisdictions of 500,000 people or more. And so all rural America is waiting to see if any of that infrastructure money will actually get to them. This is what I would love to see the House Republicans and Senate Republicans talking about. How do we make sure that their constituencies aren't dying at a greater rate than everyone else? But no, we're debating sanctuary cities. Don't stop debating those cities that aren't even in your jurisdiction. Worry about the people who are living in your constituencies and who are dying because we've divested in them. I could take this pen and throw it and hit a primary care clinic where I live. There are like 3 that open every day. And so if I have a little cough, I can go ahead and have someone check it out. If you live in rural Georgia, that might be an 1.5-hour drive to Atlanta to get that checked out. So by the time you get there, you're sicker and the likelihood of your survival is less. And so somebody has to champion rural America. Someone has to say, this can't go on. And I think that's those legislators that they have elected. And if they can't do it, then rural America needs to hold them accountable and vote them out and vote people in who will care about their health, not just their health care, but their overall health. Now clean that up, Anand, and make it by.
Yeah, well, it's always nice to go after Brian, but I think it's a really insightful point there. If I go to the Hill right now and I want to select a bipartisan issue and I want to get members from both sides, rural healthcare and rural hospital closure is always provided that as a way to get folks on both sides to the table. You know, if we can do that for healthcare related issues and hospital closures, why can't we do that for health status and for public health? Because the same disparities exist there on the health status side as they do for hospital closures. And so I think that is a great idea, and I think something that frankly, you know, I think we should take more advantage of, because there is going to be always more interest amongst Republican members vis-a-vis rural health. It's usually more healthcare. Why can't it be public health? And so I think that is very insightful.
That's very good. Other thoughts from the panelists? We're waiting to see if there are other questions from the audience. We've got just a few minutes left, so we're winding up here. Yeah, we're at the 5-minute warning. Any other thoughts from the three of you? That yeah, now's your time. You've got, an audience.
You know, I'm going to shoot my shot. So listen, for all of us who are listening, all 330 people, we have to understand that every piece of polling data that I see coming out of our polling shows that people actually know their health commissioner more now than they did before the pandemic, that they appreciate public health. And I want to implore everybody on this call not to get kind of drug into this idea that there is this mass movement against public health. I think you have a very small number of people with a giant megaphone who are talking about public health. And unfortunately, some of those people now have, I don't know, podcasts on Spotify, or might be running for, I don't know, the president. So, you know, this is what we have, this is what we're up against. And so it's so imperative for us right now to stand up and start talking about public health, what it does, what we do, how we engage, right? This is what we have to do, guys. This whole silent soldier nonsense, public health works when it's invisible. Stop it. Stop it now. Start telling people how awesome you are. Start telling people what we've done. We've increased life expectancy by 25 years, and that's going backwards because we've turned on the methods that got us there in the first place. We cannot become a nation that turns its back on vaccination. We cannot become a nation that turns our back on public health, because if we do, we threaten our safety, our security, and our economic prosperity, and we're putting the future of the nation right in the middle of the table. And that scares me, and it should scare you.
Yeah, thanks for that. Anand?
I'll just add to that and say that, look, I think we need to take back how public health is defined, right? And I think there are too many people, and maybe they're just vocal, that just equate public health with this type of mandate or that type of mandate, or what they experienced during COVID, just blame public health. And I think taking back how we define public health involves reminding Americans that public health is about really all of their activities in a day. It's about clean air, it's about clean water, it's about safe schools, it's about safe roads, it's about preventing substances from getting in your community, it's about improving health behavior and health education, improving the environment. It affects every single thing that Americans are really doing and where they live in their communities. And I think there's an opportunity for us to take back how we define public health, ensure that the public understands how public health relates to them, that it's not just some sort of what they may have perceived during the pandemic incorrectly. And so I think as we come out of the pandemic mind frame, again, having an open and honest conversation, and at the end of the day, right, it's all about trust. We keep on saying that, but that's true. Yeah, public health will be as effective as the trusting relationships that we can develop. And so I think this is a great time to redefine public health for the individuals that we serve on a daily basis.
Very good. Yeah, thanks for that. And I think, Brian, to your point, I mean, public health, CDC, health departments, good work is being done every day. that needs to have a big light on it, right? And it doesn't need to be the pandemic. I mean, we do need to get out there and be proactive about the relationships and the communication. Unfortunately, I'm getting a warning from the team, so I'm going to need to close this out and close out this webinar. Thanks for this lively discussion, very insightful. Really appreciate all of our panelists brought to us today. So in the last couple of minutes, let's continue to look forward into the future. We've talked about ways we can build a better, stronger system, especially ways to strengthen our workforce, the backbone of public health. As you saw in today's examples, without the workforce, the good work doesn't get done. We also heard about the need to build partnerships, particularly with the business and with governors, advance trust, and push policy. So looking ahead at coming attractions, CDC will have a new director, Dr. Mandy Cohen, who served as Secretary of North Carolina's Health and Human Services, as well as other key roles. Dr. Cohen knows well the challenges and opportunities our community faces, and we look forward to working with Dr. Cohen as we say farewell to Dr. Rochelle Walensky and thank her for her guidance to our nation during COVID-19. And with that, I thank all of you for sharing your time with us today. I know you'll join me in thanking our speakers and sharing their insights, experiences, and advice. A recording of today's webinar will appear on Lights Camera Action website, along with a summary and selected resources at futureofpublichealth.org. So have a great rest of your day and get out there and promote public health. Thanks.